All right, so this is the second lecture for chapter 42, and in this lecture we're going to talk about diabetes type 2 and then some pancreatic neuroendocrine tumors. So diabetes 2, some of this we've mentioned already, but it develops as a result of insulin resistance in peripheral tissues, both at the receptor and at the post-receptor stage. And then eventually you develop inadequate insulin secretion from the beta cells. So what we mean by post-receptor, so again, if we have the cells like this, we'll call it IR, the insulin receptor, and then insulin comes in and binds here. So you can have malfunction at the receptor itself, but it can also be downstream. So the insulin receptor is a receptor tyrosine kinase. So you can actually have malfunction of the tyrosine kinase portion of the receptor within the cell. You can also have defective GLUT4 transport of glucose into the cell. So you can have where the GLUT4 improperly brings in glucose. You can also have it where it doesn't even make it to the cell surface. So sure, it's triggered, but signals get crossed or lost in here, and then you don't end up moving GLUT4 up to the surface. So there's a number of different causes of this. Bottom line is that the cell doesn't respond to insulin. Typical patient is a middle-aged or older patient, often obese, often has other significant chronic medical conditions like hypertension, hyperlipidemia, etc. Obesity over time actually causes decreased insulin receptor synthesis. So not only have decreased sensitivity, but they actually have less insulin receptors, and that happens with obesity as well. So like I've said, initially, the insulin levels in patients with type 2 are actually normal to even high because they're trying to compensate for the extremely elevated levels of blood glucose. Their beta cells are still functioning properly. They're not being destroyed by some immune reaction like you see in type 1, and they're properly responding to the hyperglycemia that results from insulin receptors. So if we graph it over time, your insulin, let's say this is, normal, quote unquote, normal level of insulin. Let's say this is insulin. Over time, it could even be elevated and elevated. Since it's elevated, it's high enough to prevent ketoacidosis. So ketoacidosis is not very common to see in diabetes type 2. So it's able to prevent ketoacidosis, but unfortunately it's not adequate to prevent hyperglycemia. So what happens is over time, it keeps this bottoms out. And then what you see is that the beta cells of the pancreas become dysfunctional. It's like I was describing earlier, is that, you overuse an engine, it just blows out. The engine blows out. So essentially the beta cells, they blow out, and they've been under this constant stimulus for insulin production, and they no longer can really provide any significant amount. So at this point, they often come down below normal levels over time. And then at that point is when these patients have to begin taking exogenous insulin therapy, in addition to their current treatment regimen, which include other medications such as metformin, is a very common medication that diabetes type 2 patients are placed on. So hyperosmolar hyperglycemia non-ketotic syndrome, or HHNS. This is the type 2 equivalent of DKA. So this is very commonly seen in undiagnosed patients. So again, just like with DKA with type 1, these patients haven't been diagnosed yet, and then they've kind of progressed to the point where they develop these symptoms. Ketoacidosis typically doesn't occur in these patients, and this is a complication that results in significant hyperglycemia, so that's consistent, and dehydration. However, there is no lactic acidosis. So the biochemistry behind this, we'll use this same diagram we used to help with DKA. So again, it all stems back to insulin resistance. As a result of that, you're going to have decreased glucose utilization. So even though you have high levels of this glucose, it's not being taken up and run through glycolysis. So since you have this is out in the bloodstream, you have hyperglycemia, and you have significant serum osmolarity. So you're going to have osmotic diuresis, because if you have elevated levels of glucose, remember this is solute, so it's going to increase osmotic pull into the bloodstream. So you're going to have water coming out of the interstitial space and coming into the blood volume. And so what ends up happening is they end up peeing this out, essentially osmotic diuresis, like we say here. So it acts as an osmotically active solute, brings water in, and then you end up peeing it out. And so then eventually these patients develop hypovolemia, and they develop symptoms of dehydration. The reason ketosis doesn't occur in these patients is because they're still producing insulin. And insulin in the initial stage of this disease, it's still going to be inhibiting hormone-sensitive lipase, so HSL, and it prevents fat tissue from breaking down triglycerides. So if you have insulin and it's inhibiting hormone-sensitive lipase, HSL, this isn't going to happen. So you're not going to break down triglycerides. You're not going to have beta oxidation. You're not going to have these crazy high levels of acetyl-CoA, so you're not going to produce ketone bodies. It's just not going to happen. Versus ketosis, that's a major driver of ketosis, is that significant breakdown of fat tissue. But you just don't have that because you still have high levels of insulin. However, all of these other things are still coming into play. You're still going to undergo gluconeogenesis because your body thinks it doesn't have any blood sugar, so it makes its own, and then you're going to be using these other processes to carry that out. So again, the typical patient is an elderly patient. They have type 2 diabetes. They've developed severe dehydration, so they're going to come in with symptoms of that: severe thirst, polyuria, lethargy, altered level of consciousness. Because remember, again, you're having not only having decreased hydration, so you're having decreased perfusion, essentially maybe even decreased levels of oxygen being delivered. You're also having decreased blood sugar, so you're, again, those neurological symptoms because the brain primarily relies on glucose. You're going to have weight loss from all the urination. You can develop orthostatic hypotension, and again, that's due to severe dehydration. And then eventually patients can have nausea, vomiting, abdominal pain, neurological symptoms such as headaches, blurred vision, focal seizures, depressed reflexes, and tremors. All stems from decreased blood sugar available or being taken up into the central nervous system. They actually can progress to a coma if untreated. So on the labs, they're going to have hyperglycemia. They're going to have increased serum osmolarity, so greater than 320. So if you measure the serum osmolarity, it's going to be significantly increased, hence the name hyperosmolar, hyperglycemic. But their pH will be normal because they don't have, hence the name non-ketotic. They're not going to have these ketone bodies, which are acidic in there. So the way you treat it is you give IV fluids. You give IV fluids that are isotonic with the bloodstream, so normal saline, lactated ringers. You give insulin and then potassium. So diabetes type 2 long-term treatment often begins with weight loss, an exercise regimen, and diet modification. Like I said, weight loss can actually stimulate insulin receptor synthesis. Often medications are commonly given, like metformin, like I originally mentioned, especially in cases where, like I said, it kind of depends on what level of hyperglycemia these patients are coming in at, what is their A1C. So you may start them on a medication as well, in addition to these lifestyle modifications. Insulin, like I've said, is typically not needed at first. However, as the disease progresses, the beta cells burn out and you're going to need exogenous insulin, unfortunately. The thing about diabetes 2, though, is it can be reversed. It can actually be reversed or very, very well controlled if the patient actually follows this and does a weight loss program, changes their diet, exercises, takes the medications. There's even cases where patients can come off of exogenous insulin or come off their medications. Versus in type 1, unfortunately, because it's an autoimmune disorder that's inherent, unfortunately, that often cannot happen for the patients with type 1. One thing I want to point out here is there's a mistake in your book if you're following along there. In the book it says insulin is typically needed at first, which is not true. It's typically not needed at first in type 2, so make sure you make that small correction in your book. So just to finish out here, we have got this table comparing type 1, type 2, just the major differences. Obviously there's a lot of intricate differences, but these are the main ones that kind of help you right away when you're tackling a question stem, kind of differentiate the two. So the common age group, obviously type 1 is going to be children, adolescents, young adults. Type 2 is the middle-aged, elderly. Now, you can still see children, adolescents, college kids, people in their 30s present with type 2. You can definitely see that happen. If you see someone in those age brackets, don't automatically say, oh, it's type 1 for sure. Make sure you look at some of these other things. Pathogenesis for type 1, like I've said, is an autoimmune mediated destruction of the beta cells. Type 2 is, peripheral tissue resistance, and then eventual failure of the beta cells. Type 1 is not related to obesity. Type 2 is. A weak genetic cause from the studies, 50% concordance in identical twins versus there's a strong genetic predisposition to type 2. Insulin therapy is always needed for type 1 because they're not making any of it. Type 2, not initially, but frequently used during later stages of the disease. Ketosis, yes, very rarely seen in type 2. All right, so to close out this lecture, we're going to briefly talk about pancreatic neuroendocrine tumors. Probably a topic you're going to more likely encounter in your pathology course, but these tumors have some really interesting biochemistry, and they utilize a lot of what we just talked about with diabetes, and then a lot of the concepts we talked about in Unit 3, where we talked about insulin and glucagon and the kind of the different regulations of metabolism. So these are kind of an interesting clinical correlate that I'll go through briefly that maybe could show up on your biochemistry exams, definitely on a pathology exam, and definitely on the USMLE. So you remember the pancreas. It's kind of shaped like this, and it has like a little tail at the end here. So if this is your pancreas, just to review, you have three types of cells. You have the alpha cells, the beta cells, and then the delta cells. The alpha cells secrete glucagon. So a glucagonoma is a tumor of the alpha cells, The beta cells, as we've mentioned, secrete insulin. So an insulinoma is a tumor of the beta cells of the pancreas. And then delta cells secrete somatostatin. So a somatostatinoma is a tumor of the delta cells of the pancreas. So first we'll talk about insulinoma. It's a tumor of the beta cells of the pancreas. Sometimes these tumors are benign, sometimes they're malignant. Either way though, they're involve the beta cells, which, as we've said, produce insulin. So these tumors are going to produce and secrete abnormally high levels of insulin. So these patients are going to come in with really high levels of insulin, and as a result of that, severe hypoglycemia, because they're going to be constantly, it doesn't matter if they're fasting or in the fed state or just exercise, always producing insulin, always going to have hypoglycemia, especially when they're fasting or after they exercise. And oftentimes these can trigger patient's symptoms. So they're typically going to complain of recurrent headaches, kind of the symptoms of hypoglycemia that we went over. You can see why we went over that. Feeling lethargic, diplopia, blurred vision. Again, these all stem back to that the nervous system, especially the brain, primarily relies on glucose. If severe hypoglycemia develops, it's just like any other patient that develops severe hypoglycemia. They can present with seizures or even in a coma. These symptoms often resolve after they're given glucose. So that's kind of the key thing here is they're presenting with these symptoms and then you give them like a glass of orange juice or some crackers and then they resolve. Kind of maybe tips you towards thinking maybe it could be an insulinoma. And there's actually a term for this, the Whipple triad. And so this is where patients have low blood glucose, symptoms of hypoglycemia, and then resolution of those symptoms after the blood glucose returns to normal. Diagnosis, so you measure serum levels of glucose, insulin, and C-peptide. So C-peptide is actually cleaved from proinsulin. So you've got, let's say this is proinsulin, and we'll draw a C here. So C-peptide. So let's say this is insulin, let's say I, and all of this is proinsulin, which is a pro-hormone precursor as part of the insulin synthesis process within the beta cells. So as you create insulin, what happens is you cleave this off. And so then you have C-peptide. And so you can actually measure both of these in the serum. So patients with insulinomas, they're going to have low blood glucose due to high insulin levels and high C-peptide levels. The reason for that is because they are synthesizing an abnormally high amount of insulin as part of the insulin process. As you secrete more insulin, you're going to cleave off more C-peptide. Now, what's a common USMLE question is they'll give you a patient, you kind of can't really tell, are they just hypoglycemic? Do they have an insulinoma? Or are they administering exogenous insulin to themselves? So some people do this for weight loss and other reasons as well. It's very commonly they'll say it's like a healthcare worker of some kind. So they'll say a physician, a nurse, someone who would have access to getting insulin pretty easily, a pharmacist. They'll say someone like, oftentimes that's kind of a tip off that it's more they're just giving exogenous insulin, but always want to check, make sure that if they give you this, they're going to have low blood glucose, high insulin, but these patients are going to have low C-peptide levels, because exogenous insulin doesn't have C-peptide cleaving process. Their endogenous insulin synthesis is normal. There's nothing wrong with it. Their beta cells are synthesizing and secreting normal levels of insulin and C-peptide. Since they're giving an exogenous level, they're going to have high levels of insulin. So that's how you tell, bottom line, that's how you tell exogenous insulin when a patient giving themselves exogenous insulin from an insulinoma is the C-peptide level. That's the most important part. Now back to patients with insulinoma. The treatment there is usually surgical resection of the tumor. So a glucagonoma, again, the pathophysiology of this is a tumor of the alpha cells of the pancreas that are producing and secreting an abnormally high amount of glucagon. All you have to know is what glucagon does. So you're going to see high levels of gluconeogenesis, lipolysis, increased blood glucose, decreased serum amino acids, decreased erythrocytes. Again, these are all downstream effects of what we talked about when glucagon is secreted. Clinical features, necrolytic migratory erythema. This is kind of just a characteristic rash or skin lesion that you're going to see in these patients. It's very characteristic for glucagonoma. It's characterized by red blisters, swelling in the areas of skin that are exposed to friction, so like the lower abdomen, the buttocks, the groin. And then on top of that, you're going to see hyperglycemia because of gluconeogenesis. Also going to see diabetes as a result of that, if they've had this for period of time, they can develop diabetes, and then commonly seen along with weight loss and depression. Diagnosis, you're going to see just abnormally high levels of serum glucagon. As far as treatment goes, you give octreotide, which is actually a somatostatin analog, which will inhibit glucagon release from the alpha cells. So it's kind of a temporizing measure. You give that at first to inhibit synthesis, and then eventually you will surgically resect these tumors. Lastly, a somatostatinoma. Pathophysiology of this is a tumor of the delta cells of the pancreas, again producing and secreting abnormally high amounts of somatostatin. So somatostatin is an interesting hormone because it actually inhibits the synthesis of a lot of different hormones. It inhibits the synthesis of insulin, glucagon, secretin, cholecystokinin, gastrin, vasointestinal peptides. So you're going to see decreased levels of all of these, and a result of that, you're going to see clinical features that correspond to the physiology of decreasing all these hormones. So you could see diabetes due to decreased levels of insulin, steatorrhea and gallstones because you don't have bile produced, because cholecystokinin stimulates bile release from the gallbladder and from the biliary system. Hypochlorhydria, which is low chloride because decreased gastrin, because gastrin stimulates synthesis and secretion of hydrochloric acid within the stomach. And so you're going to see decreased levels of chloride as well. And so the way you treat these is surgical resection. All right, so that closes out the second and final lecture for the diabetes chapter.